admitted to the emergency room, you could also then notify them, oh, and by the way, they have a transportation need. Being able to notify somebody that while they're doing some care coordination effort, if you know they're going to have trouble getting transportation to your office for a follow-up visit, that can be something that you are now equipped to handle and set up the patient for better success. So, so ACRES attributes is a place where social determinants of health data can help improve in other care in other contexts. Okay, so now's the time that I'm going to talk about the vendor multiplicity when it comes to social referrals. And for this context, I'm breaking things down into a couple of different actor groups. I'm calling out Michigan 211 here because they are, in some cases, acting only as a community resource directory, and in other cases, they are acting as a referral service themselves. And so they're kind of a unique entity here. If you're unfamiliar with Michigan 211, they're a service that you can go to their website or call on the phone, and anywhere in Michigan, you can say, I have this social need, and they have a resource directory of social programs, and they can help you get connected. Very similar to what we're trying to do with social referrals often. So we have the community health innovation regions, or communities in general. We have all these social service referral vendors. We have Michigan 211, and because I'm talking about MiHIN, I'm separating MiHIN out in this particular conversation. And when you have a vendor that is collecting and storing information, you in essence are creating a silo. But one silo isn't that big of a problem. If everybody was using one vendor, then all the data would be stored consistently. All the data would be in one place. We could report on it all day long. You wouldn't have interoperability or integration concerns. When you start to have a couple of vendors, it still isn't a major problem, especially if they're separated by geography. If you have a community in the Grand Rapids area all using one vendor, and a community around the Detroit area all using one vendor, and a community all in the Upper Peninsula all using one vendor, then the only point of interaction is when you need to do state level reporting, or if there is some one-off situation. It's not that big of a problem. The problem exists when you start having a lot of different vendors. I'm actually not going to get into this diagram, but you can see here, this is just an illustration that there's a bunch of different vendors that these communities are using, and that there are a lot of them. When you start to get a bunch of vendors, and especially when those vendors are working with organizations that are in the same geography, then you have split communities. You have in the Detroit community, people using PCE, people using Riverstar, people using Find Help. And if they want to make a referral from one to the other, you either have to use multiple platforms or do something out of band, like call them on the phone. There's not a systematic way that you're going to be able to make a referral in the status quo of today. Organizations that need, yeah. So that is a fundamental problem that we are starting to see emerge, is that there are communities that have multiple vendors in existence, and so a whole community referral program isn't really possible today. With that, there's really three options on the table. One is MiHIN doesn't get involved, and there may be some integrations that are built between some of these, but mostly things would stay disparate. The second option would be for whether this is MiHIN or somebody else, trying to get a single vendor to be the vendor for the whole state, in which case all the data would be in that first picture where there's not problems. All the data is stored the same way, everybody can communicate with each other, and it's like a utopia. The issue is that there are a lot of communities that are very invested in the vendors and the options they've chosen. There are community health innovation regions that have been doing things for years now at this point, and I don't see it be, at least from a MiHIN perspective, a realistic approach to try to promote one single vendor. So the third approach is something like what we're calling interoperable referrals. And in an interoperable referrals world, you can use the vendor of your choice. You can benefit from all of their value add functionality in their application, but then you'd be able to make a referral to somebody who might not use the same platform, and MiHIN or some neutral third party would facilitate the handoff between vendors from one to the next, so that referral can make its way, and when they accept or don't accept or have questions on that referral, we could facilitate a handoff back to that first vendor, and so on. This is a really business level way of thinking about the design that we have in mind for interoperable referrals. And you can see here right off the bat, Michigan 211 is there on the bottom left. Unless things change, we want to leverage Michigan 211. I personally, if any of you know me, I've been involved in trying to get the health directory at MiHIN to be a health resource directory, and I'll just say I'm not interested in trying to create a community resource directory. That's not where I see us providing the most value. And Michigan 211 is already working on that. So what we would do is we would like to partner with Michigan 211 to be that resource directory that you could look up, find anybody who offers the service you're looking at. Theoretically, we would want them to have, are they accepting new patients right now? That sort of thing. Once you've found the organization that you wanted to make a referral to, your application, if it's outside of your referral network, your vendor or your application would pass a payload to MiHIN. It would have an identifier for that organization that had been pulled from the Michigan 211 resource directory. So MiHIN gets it and says, okay, we know who this is, and we can figure out where to deliver it to. We would be using the health directory to store endpoints, but we're not expecting anybody else outside of MiHIN at that point to log into the health directory and look at anything. That's just our own internal routing engine. We would make sure that when a referral is accepted, that an active care relationship would then exist between the patient and that new organization. And then we would store that referral history similar to, just like as I was talking about with Acres attributes, so that that information can be surfaced to someone in a context that might matter, like I was describing before. Are there questions on our thoughts on interoperable referrals before I move on? We're definitely going to have very shortly, I don't actually have time, but maybe 10 minutes, we're going to get to, I'm trying to solicit feedback from you, but right now it's just questions.
Can you just explain briefly maybe why it wouldn't be tied to Acres in this, the updating the history, the referral history database?
Yeah, so the Acres attribute intentionally does not have much detail. And so we would create an Acres attribute, but it would just say, this person has a transportation need. If you want to know more, go look here. And in this case, we'd have a referral history database that has the when a screening was performed or when a diagnosis was made, where the person was referred to, what intervention was done, That is not going to be contained in the acres attribute.
That's helpful to know. And I just want to parking lot this for us to come back to. You said at the top, we talked about Z codes and long-term implications of Z codes on folks. When we think about SDoH needs, they are sometimes episodic. What does it mean for a patient potentially to have an experience of food insecurity or housing insecurity to sort of follow them in some of these records? So I know partly the fact that maybe some of that detail wouldn't be included in these attributes in the long term, I could see as an upside, but I want to parking lot that for us to come back to in terms of conversation, just in terms of the larger ethical considerations for how we're using some of this Z codes and other identifiers related to this SDoH vulnerability.
Yes, that's going to be really good conversation when we get to it. Thanks.
So Michael, am I to assume that the 2-in-1 system is going to merely function as a directory? That's it.
Well, that is a loaded question. We cannot. I'm going to try to be as comprehensive as I can, but I do not control Michigan 2-in-1. Today, they are working on being able to help organizations that right now they have a service where they say, if you have a patient whom has a social need, just send them to us and we will help get them connected to the right resource. And they'll have an actual human being there who will help walk that person get connected. And that is a service that they are offering, but we would not be stopping them from doing that. We would just be, as far as their interaction with MiHIN is concerned, we're focused on them as a resource directory.
Yeah, Mike, if I can, this is Mike Klinkman. I can also jump in here. The 2-in-1 has probably done different things in different regions through its history. And even as long ago as SIM, the 2-in-1 system there created a role of 2-in-1 navigator that worked much like a care coordinator would in some other regions. And so that's one functionality that Michigan 2-in-1 is looking at. They're also developing, they're also trying to develop a role as a vendor of community referral platforms, and they've experimented with that in Southeast Michigan. So we know that 2-in-1s are going to do different things, and depending upon match between what they can offer, how strong they are, how established they are in different Michigan regions, they may take on different roles. But the one essential role that it feels like to the MiHIN team is that we need to have a valid, reliable, updated, and comprehensive list of community resources that isn't sort of stored away in little corners in individual community organizations' memories, but is really a shared and definitive resource. And that's a function that probably in the end is something that the 2-in-1 system can do better than any of the other potential participants if we share. And it's something that it feels like, to us at least, should be supported by the state as an essential resource, because that's also populating my bridges. So that's why we called that one out as being something that we thought was a critical piece of all this. 2-in-1's role and the other places where it's working will evolve, just like other vendors are going to evolve their own strategies and their own ways to work with community. Make sense?
Yeah, and that's why I'm calling it a directory, because basically it's a yellow pages, right?
Yeah, it's a souped up yellow pages that we hope has more more content. One thing that's missing that we'd love, and we've heard loud and clear community organizations would love to see, is a way to update capacities for services. And so we're trying to figure out, in working with 2-in-1 in the state, how that could be accomplished without an inordinate amount of work on everybody's part. So yeah, exactly. So think of that as a great yellow pages for the future.
Thanks, Dr. Klinkman. All right, I'll move on. So our goal specifically for that interoperable referrals scenario that I just overviewed is that we want to connect these referral networks. We want to connect them because there are multiple referral networks in the same geography. We want to connect them because we do want to measure referral volumes. And we also want to connect them because MiHIN would like to be able to share that referral history with the care team when it is legally applicable and possible. And so our goal in that respect is not to create another silo, but to try to create a way for us to be able to pull the data in from silos when appropriate and redistribute data back to the right silos when needed. And so I was completing the, we've been talking about silos for years, and I've never heard anybody talking about the grain bins and talking about a tower that's going to redistribute the grain. So now that I've kind of overviewed the interoperable referral scenario, let's talk about use cases that are going to support identifying and resolving social needs. As I mentioned earlier, screening is really the triggering event that can start any process. And from a data perspective, from a computer perspective, having a triggering event is a really valuable thing to start a process that is going to be successful. And so that's the lowest hanging fruit in my mind, is starting with screenings, though screening is not the objective. And that is something that I think a lot of people whom are getting into the social determinants of health space and they're trying to just get excited about whatever activities are happening in the ecosystem, they get excited about screening. And I just wanted to articulate that we understand screening is not a goal in and of itself. Screening is just an event to start other activities like finding out what the actual root cause is with the person and trying to resolve it. Really, each step in that circle that I just overviewed can be its own use case, but some of these we're not starting with our focus right now because we have to have a point at which we're starting. And because social need screening can be a trigger point, we're starting there. And then the social need interventions and intervention history is the other one we're aiming at tackling sooner rather than later. So let's talk about what we have in our current state. As I mentioned, during the state innovation model, we began receiving social need screenings, but at that point, we weren't doing any sort of intelligent redistribution. We weren't doing any sort of aggregating. MiHIN was basically just a pass-through for the program so that the state innovation model had those metrics. Last year in 2021, we enhanced the social determinants of health use case, and it has come up over and over and over again. The social determinants of health use case is not really well named. It's not aimed at all of social determinants of health. It would be better called the social need screening or social determinants of health social need screening use case, something like that. But it's really screenings that use case is all about. So it is live, and the enhanced use case 2021 was all about opening the doors, starting to receive data. 2022, we've been building out our infrastructure and preparing for the capability to redistribute those screenings back to the care team. But here's some statistics on the screenings that we've been receiving so far. There were 109,000 total screenings done, and the highlight in yellow is showing that we have an 18% positive screening rate on the screenings that we're receiving, which I don't particularly myself have and I didn't have an expectation of what that percent was going to be. So I don't know if that was, I didn't really have a moment where I was like, oh, that's higher than I expected or lower than I expected. But knowing that we have an 18% positive screening rate right now is a really interesting metric to keep an eye on. we are right now focused on these social, I'll call them social determinants of health domains. We're focused on these domains. And what we've done with the social determinants of health use case since the SIM project was during SIM, you had to ask the same 15 questions that every other SIM participant was asking. And, or you were, the intent was that everyone was anyway. What we came to find out is that different communities and different organizations want to choose different questions based on their audience, their community, their customers. And so in 2021, when we did the enhanced use case, we opened the door and said, you can ask any screening questions you want, as long as they map to these domains that are recognized by the Gravity Project. As long as you can map them to this domain and tell us whether a need was positively identified or not by the answer that you got, we're okay with the questions you're asking. And we restructured the way that we were getting the data so that you could, participants could give us any question and any answer, and then map it to a domain and a need was identified or not identified. That is really what I wanted to cover on this slide, is that these are the domains that we are aimed at. There were a bunch of challenges that came up through the social needs screening efforts. Number one is that there is no ubiquitous standard payload that we can point to. When MiHIN started with the admission discharge transfer service, there's a lot of conformance that has happened over the years, but at least we had the ADT standard that we could start with and point at. And there wasn't really a good standard like that for screening data. There is a way to communicate it via FHIR, which, as I mentioned at the beginning, we're going to start pushing people towards. But there was not an expectation that the community at large, or the state at large, would be able to produce things in a FHIR standard at the time. So we ended up going with a CSV, or comma separated value standard, for communicating the screenings to us. There's definitely conflicted expectations of Z codes, and that's why, Alex, I'm really looking forward to that conversation. I think that the payers all have one expectation, and that's largely because they're working with diagnosis codes already, and it's something they know how to deal with. But yeah, there's conflicted expectations on at what point we can use a Z code. Another challenge is that the Gravity project wasn't done. They're continuing to plow through the social determinants of health domain and codify new things each year, and they have a roadmap that we're trying to keep up with. So we have an annual alignment process that we've had to adopt, where in the fall of each year, we're going to do a environmental scan and specifically hone in on what's changed in the Gravity project, what new things have been released, and kind of retool our see if there's anything that needs to be updated on the specification that we're currently accepting. The data collected outside of healthcare may not fall under HIPAA. This is a big one that we have not figured out a solution to yet. You know, when a lot of people think about HIPAA, they think about the fact that data needs to be encrypted and secure. And so they think of HIPAA as that security piece, but really there's two sides of HIPAA. There's that, but there's also HIPAA gives you permission to share. HIPAA says that when it's a treatment payment operations, or whatever that acronym is now, when that scenario exists, we can share physical health data without getting explicit consent. There's not necessarily that assumption when it comes to community health organizations that maybe working with people to actually address social needs, but they don't have the healthcare protections of being able to share that data without explicit consent. And then because we don't have this ubiquitous standard payload, nobody's system is designed out of the box to ingest the screening data. And so it's already presumptuous of me when I say we're going to distribute these screenings out to the care team. It's very presumptuous, and I realize it, that we're talking about putting a burden on people whom are going to receive this data to figure out what to do with it. And so part of this group I'd like to do is talk about what expectations can we make, and what is appropriate, what's an appropriate approach to try to unify people in how we are handling screenings and able to surface this information. We did make some reports from the screenings that we have coming in now. If you are participating in the social determinants of health use case, you may get access to this report. It is all de-identified aggregate data, but it is a way that you can look at the data from a population level and look for those trends, as I was describing earlier. You could look at things over a geography or by other factors. Actually, I'm going to go back, and you can see the dimension thing on the top right. You can see age, city, county, domain, gender. These are different stratification methods. These are different things you can use to stratify the data. So you can say, I want to see all the positively identified needs by county, and then within each county, the age breakdown. And you can start to see, you can look for trends within the age groups. You can look for trends within gender, and you can have up to 5, you can drill down 5 levels deep. So you can say, I want to look at it within a city, within an age group, within a gender. I don't know how you keep going, but it supports up to 5 dimensions of drilling down. Yeah, so that tool does exist today. We also ran into challenges when it came to referrals. The first one, the need to support a multi-vendor ecosystem, which I think I've pretty sufficiently covered. There's not a common resource directory. And that's definitely a challenge that we have to solve for when it comes to crossing referral networks. When we join a referral network, there needs to be a way for one network to know who's available in the other network that they could refer to. And so having a common resource directory is a challenge that without that 211 partnership is going to be a significant lift. There is a taxonomy out there for identifying services that community-based organizations can offer. Some people have referred to it as the heirs taxonomy. We were trying to get to a licensing agreement on that taxonomy, and it turns out when we met with heirs that they told us that the heirs taxonomy is actually a misnomer, and it's the LA County 211 taxonomy is really what we should be calling it. And heirs is a group of people that surround and try to find best practices and talk about best practices on the use of the taxonomy. But anyway, getting licensing for that taxonomy proved to be more challenging than we anticipated. Their whole pricing model is really geared for a per organization, and they're in their minds, they're thinking of 211 organizations throughout the country. They want each 211 to pay dues to them, but their model is not geared at a scenario where we might need to share that taxonomy amongst our participants, and yeah, there were a lot of challenges about whether everybody in Michigan has to have their own license. If we could buy a license that would just cover the Michigan region, that was definitely a challenge. We did end up coming to a general agreement with the LA County 211 that for the way that we were planning on designing things, each organization would not need their own license. Thank goodness. MiHIN's going to purchase one, and if we partner with if we partner with Michigan 211, then obviously they would need a license, and the rest of the participants would be covered. Yeah, same thing that I called out for the screenings is that data outside of healthcare might not fall under HIPAA. Expectations on referral receivers without compensation. There's no financial model right now on social referrals. These community-based organizations that are participating largely are doing so out of altruism for their mission, that they want to help people get whatever need they help with met. It's very possible that the financial incentive that healthcare payers have to keep people healthy gives us a model that provides compensation to the community-based organizations providing the services, or at least providing compensation for the time spent handling referrals from healthcare organizations. We're still pursuing that, but that's definitely a challenge that we've seen and a potential approach to it. So that was me getting through all of the overview that I was going to make for MiHIN today. Your mission as a group is to pick apart the things that I have gone over that need to get drilled into, that we need to say, this is good, this is not good, what things don't have enough definition that you feel like needs to have something very particular. We want to hear where you want to go. And yeah, we want to do that, and then I'm going to save a little bit of time at the end where we'll go through agendas for future sessions. So at this point, I'm going to open it up. Just like you had questions before, you can ask questions now, but also we can just discuss how do you feel about MiHIN's vision for addressing social determinants of health? And again, I didn't say this actually. We do view our role more specifically on the data exchange aspects. We're not actually, we're trying to enable people to address social determinants of health. We're not ourselves trying to address social determinants of health. So what are thoughts?
So this is Stacy, and you know, the thing that really I found so exciting is the notion that we can begin to use these data to improve population health, and particularly the ability to look by variable and location, stratify. You know, that's what we desperately need. And so that piece in and of itself is very, very exciting and compelling.
Awesome.
Mike, just a recommendation: when you organize the next meeting, can we have some CBOs in the group? I don't know if there are any CBOs in the group, but it would be good to include them.
Your recommendation is heard loud and clear. We were actually organizing two different groups because we were afraid that they were going to get too big. And so one group is specifically focused on the community side.
I have an issue with that because now you're creating silos again, especially for those POs that are working in a neighbor environment and are actively involved with CCBHCs and CBOs. So I think there should be some type of intersection. So those that might be engaged with CBOs, there could be almost like a third group.
Okay.
But we're talking right now you've got your healthcare group, and then you've got your other healthcare group, which is the behavior health group. And there needs to be some type of marriage finally.
Yeah, but maybe I can, this is Mike again. Let me jump in and rescue Mike from this, because there's I wholeheartedly agree with the idea of bringing community organizations and healthcare together. There's two problems with it as things stand right now. The first is that across the country, the CBOs that have been engaged in these processes are the largest, usually best funded, already technologically savvy CBOs. And that's good, but what it leaves behind in its wake are community clinical linkages and partnerships that are only partial and have by and large stalled. I think we talked about this in some of the other MiHIN sessions. And we've done some really big deep dives in other states to figure out why they stalled. And almost always it's because the representation of CBOs doesn't reflect the diversity and the complexity of the community-based organization world. So we want to bring CBOs together with provider organizations and with local governments, because that's the triad that probably makes sense for community information exchange, and make sure that we weave in other people who need this kind of information, like behavioral health providers or even the corrections system. But we really want to give community organizations some time and some assistance in self-organizing and figuring out how to handle diversity, or at least figuring out who can speak for the smaller, less connected, less technologically savvy community organizations, so that we can get past this first wave of implementation where we've gotten stuck so many times. And so what we're doing with this strategy is we're trying to get the provider organization community to kind of talk among itself, to give MiHIN feedback about what we're getting right, what we're getting wrong. That's what this is starting to do. We're going to do some of the same things with community organizations, and that should lead to a much more fruitful merger when we get a little bit further down the road. So feedback about that from you all would be really helpful too.
Yes, so I'll just make one more comment about this. I believe there are 11 CCBHCs in Michigan that really move beyond just the CBO environment. They move into different areas. Perhaps MiHIN should consider inviting the CCBHCs to be part of a subset discussion with POs.
They have been involved already in a few cases because the regions that we have talked to have CCBHCs, but yeah, we'll take that in.
Yeah, mid-state here, we have 3 that are demonstration sites and 1 that is a SAMHSA grant site too.
Good. Comments from others? Does it make sense kind of in how we just talked about trying to prep domains or sectors for more productive conversations? I guess we can take that as tremendous assent to that, folks. For folks who do have concerns, feel free to send Mike or Lisa or me a message eloquently stating why it's a dumb way to go about this.
But I do appreciate your feedback very much.
Now, this is Joe from Midstate. I have a comment or just a wonder. I know this is based on kind of like getting a referral and trying to address the social determinants, and it's, self-reported. Oh, come on. With your analytics tool, have you ever thought about, and this is what I'm starting to play with, using publicly available data sets, like down to the census tract level? Like, here's where there are grocery stores here where, here's what the income is, like down to the census tract. And that if you have an individual, here's where they sit, and this is what you see. And just to supplement, I don't know.
Let's go with it's not been proposed. It's definitely something that has crossed my mind, but it's not something that we had really gone into. one of the things that we are hoping to accomplish is get, actually, that's a good topic, is for us to talk specifically about reporting and what kind of reporting would be most helpful, and what data might be out there that, so when we get to the agendas, I'm gonna, if you don't mind, put improve reporting as a topic.
Sure thing.
And again, this is Mike. Sorry to jump in one more time. We know that there is some work on this just getting underway. Michigan Medicine's Family Medicine Department, where I work, has worked with a population health tool called FATE, which is Population Health Assessment Tool. I forget what the E stands for, by the American Board of Family Medicine, to do exactly this. They're trying to use health landscape data and other publicly available data to create what they're calling a community vital sign, but really is an area deprivation index based upon that data. My guess is that it's going to be complementary to individual level data, because census tracts are also diverse in many cases. And one of the weaknesses that we're seeing as we're starting to look at this is that it tells us what census tracts might need attention, but not which patients might need attention. So it can be useful on a broader population health basis, or your practices populations basis, which is what the Academy was thinking for family medicine. We also know that Phoenix, Wayne State's population health group, has tried to create a database using publicly available data for census tracts in Michigan to identify where people are most at risk for poor outcomes related to cardiovascular health. And so those things are starting to get going, but the weakness is their strength. Strength, public health data; weakness, public health data; strength, census tracts; weakness, census tracts. And so it's a great pair with what we can do on the ground with individual patient or client work. So this is a great conversation for this group as we move forward, especially with the interest in population health.
Yeah, for sure. The census tract data is, correlational at best, but it could be supplemental. Like, what areas should we be focusing on? Or if we're not getting self-reported things and we have large populations coming in from areas with this, do we need to, I'm just thinking ahead for, like, clinically, which ones do we ask more than just a screen or something like that? Just to inform what we're doing. Yep.
Exactly. So you look at it and you say, this census tract, we probably, if we have access to community health workers, maybe that's when we send them out into that community to do either, local on-site screening, or focus on those patients and flag them when we have contact with them from our primary care practices, to say, okay, these are the people we really ought to be screening, instead of adults that are, coming in just for routine health maintenance. So yeah, I know we've talked about that sometimes when we've talked to provider organizations about how practices and clinicians can implement some of this work, but it's a great conversation topic for this group.
I would say I have quite a few ethical questions about this that we can get into more detail, as Alex said, but I think there's also kind of one-way thought about this that could stand to be broadened some. In other words, the on-ramp doesn't have to be just providers. Once, a patient gets with an organization, they may need an on-ramp to refer the patient on to a different organization as well.
Oh, absolutely. I think I know at least the Shire in Jackson, as it ramped up to do clinical community linkages, started from that perspective. We also expected that much of the screening for social problems would not be done in healthcare, but would be done in community. And we built into the system an on-ramp for people with medical needs that were identified inside the community to get into the healthcare system. So yeah, it was always considered any open door thing. And I think that we should, as a group, make sure that we're clear that this is not just a very narrowly healthcare centric use case or set of use cases that we're designing. So really good point.
And the other thought I had was, I'm not seeing a lot of patient self-determination here.
MiHIN kind of has, this is Mike again, I'll just say this. This is personal opinion from working around the country. MiHIN's lane is trying to move data, not to, I guess, influence or prescribe the approaches to take, or the, I guess, the standards by which we expand this. Work in other states has sometimes focused only on the community member perspective, and that's really pretty valuable. I can think of work in Colorado. And as we get past some of our conversations about technical building blocks that Mike laid out so nicely here, I think we should bookmark that issue as well. If nothing else, we can then take it back to the state and the DHHS social determinants of health task forces and the health equity task force and work to make sure that those ideas get worked through as we're trying to understand consent and data sharing and governance strategies that in the end will probably guide a lot of this work. Those just aren't in place yet. You heard that HIPAA is in place for healthcare, but not for social care data. That work is going on, but it's really hampered by the fact that we don't have a model for governance or shared control or who sort of owns this data as these initiatives get rolling. And that's policy work more than kind of MiHIN data transmission work, but it's really important to pair to this. So yeah, clearly heard. Keep bringing it up and we'll try to find a way to get specific questions back to our partners in the state where we can.
Thank you.
Awesome. We can tell that Dr. Klinkman has already thought long and hard about this stuff. So we have just about 10 minutes left. So I have the topics that I put on the first slide here. I have the other topics I've heard people mention here. I don't know how many sessions we need to have or want to have. So this, I want you guys to influence what's the highest priority thing to talk about. How many things do you want to try to get through in a session? How many sessions do we think we need? Yeah.
Sorry, this is Diane. I'm just wondering if additionally, earlier in the discussion, we heard several folks mentioned the whole issue with Z codes and the lack of comporting with many social needs screens used. I'm just wondering if that's what the group feels about that in terms of attacking that as an issue as well.
I know you're taking notes, Michael, and I know you put in the piece around the ethics. So there might be a couple ways, a couple areas to address that based on Diane's question, which I agree with. I was going to ask a separate question, which is, to me, it seems intuitive. I think to a certain extent why MiHIN would take on this role and particularly integrate with 211. But I'm wondering, just in the sense of kind of fairness and helping me think more broadly about this, who else could do this? And I know that's a bizarre question because it's sort of asking you to name who your competitors are, but I'm sure you've done that analysis. I know at one point MiHIN was talking to Unitas. What else could this look like? Who else could do this role? Maybe not as well, but like, what are the alternatives? If we were really trying to think expansively, again, I'm recognizing it's kind of a silly question to ask you all to answer for us, but I think you all are you've done the work to think through this. You'd probably be able to answer my question and also tell me why they wouldn't do it as well as you.
Sure. Well, in complete honesty, if you were asking me the #1 organization that I thought had the greatest chance of success, I would probably say United Way. The United Way of Southeastern Michigan, I think, is already trying to start doing community information exchange and stimulate similar types of activities. Their solution is the reason I think our solution is sufficiently different from theirs is that theirs is still more or less a one vendor centric model. The difference is they're not thinking of themselves as a vendor, they're thinking of themselves as send us the actual people, and we have employees who can walk with that person and connect them to a resource. But yeah, we have been in conversation with Unite Us and Find Help. We are meeting with WellSky for the first, I think we actually just met with them. My brain is a little foggy. But at any rate, we've definitely met with Unite Us and Find Help. Both of them have cool solutions. I think the real problem is that it's, well, first of all, there is bad blood between Unite Us and Find Help for sure. And they have both said in a little bit nicer ways, but they will not work together. They will intentionally not work with each other.
And I'm sorry to interrupt you. And you're absolutely right. No, and I completely understand that. But I'm putting in, I see Mike's off mute now, so I'm sure he's got an answer to this too. But I want to put a finer point on the question, because I think the other way of asking it is, I look at what the United Way is trying to do, and I'm going to try to speak for them, but I can't do that adequately.
Sure.
I look at what United Way is, and the reason I know about the CIA is because we're doing it with them at Henry Ford. What I look at them doing, though, is trying to replace the Unite Us or the Find Help in that last mile work directly with our patients or with the community members. And I don't look at what you've presented today as doing that connection work. Now, you've talked about relying on 211 to do that. And in the Detroit area, southeastern Michigan, United Way owns the 211. That isn't the case with all United Ways across the state. So I'm trying to do that differentiation activity. I still look at that as a little separate. What you all have the power to do, my United Way certainly doesn't, in terms of ADTs and some of the other acres files and some of the, that groundwork, interoperability and data sharing. So that was the kind of point I wanted to get to. Other than MiHIN, who has this capacity, right? Because I know that the final end, the patient navigation and engagement, that's, you guys aren't proposing to do that, I don't believe, and there's a huge market for it.
So yeah, this is Mike again. I'll lay out probably what I think is the sort of big picture perspective here. Alex, there's nobody in the country right now that has succeeded at being this broad, let's call it a hub, at being a broad, inclusive, federated hub to be able to collect and share information that is created in regular contacts with patients and clients. Each of the vendors in this space that have been rushing to get into positions of kind of primacy, kind of like the electronic health records vendors did, can do parts of this. But what they have not done yet is figure out interoperability. We've seen this in a lot of the conversations we've had in the Gravity Project, and the roadmap that the standards organizations are developing for moving medical information had to be adjusted twice now to account for the unexpected and difficult to overcome diversity and differences between purpose of sharing information on the community side, purposes for sharing information on the medical side. And so what MiHIN is trying to do is walk a tightrope to say, we want to be able to help with the roadmap and the guardrails for how information moves and what format makes sense to move it in, and then encourage multiple participants to follow those rules so that the information can move regardless of which technology you wed yourself to. And that, I think, is MiHIN's kind of essential function in this. MiHIN doesn't want to have products in this space that they market. We might be able to have a default way to assist very small food banks, for example, but we're not going to have products in this market. And we know that people make choices based upon factors important to them locally. It may be that there's a very strong and robust United Way doing a good solution. It may be that one of the shires developed a solution that works for them and they want to build it. So we've got to figure out how to make everybody work together or play together, just like we had to figure out how to make the electronic health record vendors play together. And I don't know if anybody else is prepared to do this. We've had conversations in several states and talked to several other states' health information technology roadmap folks, and everybody's struggling with the same issue. So I'm hoping something evolves, but I don't think there's a one best way right now. So we're just trying to create a playing field that everybody can play in. Does that make sense to everybody?
You got it. Yep, hit it out of the park. Thank you.
Okay. And that's where we're at. And that's why everybody's contributions in this group are going to be important, because your ideas about what works for you are what will help us to modify and make this work better. You know, we came into it with our best guess based on a lot of conversations and back and forth with other places about what would be the kind of first bit of work, but that's going to have to be honed and improved by real world conversations with you all. And those conversations will get into depth if it's a group of providers like you all from various perspectives in that chain of healthcare provision that can sharpen things up, just like we'll have to do the same thing with community organizations to help them sharpen things up so that those conversations, when they come together, are useful. That's where we're at.
All right, so there's two minutes left. What I think would be the best approach at this point is I will send out a survey to everyone in this group with these topics, and I want everyone to rate them in the priority of interest you have, and then we'll use that to drive what the next agenda is, and go from there. Thank you everybody for joining. I think this group is going to be really great, and I think we already have session 2 scheduled, and I think the date was the first week of June, but I don't remember the exact date. But I look forward to seeing you all there, and have a great day. Have a good weekend. Have a good Memorial Day.
Thank you very much.
Thank you.
Thanks, but